Et tout d'abord, merci aussi
And I want to thank Nathalie Bajos for hosting this symposium as part of the chair on health inequality, and thank you for associating the ERC Gendhi. And I will present some of the work that we've been doing there. I will focus on socialization, one of the main focus of our research with the intersectionality that Nathalie talked about in her introduction, and we'll talk about embodiment, and Michelle will tell us about that. I will try to highlight what we do in the Gendhi project, but I will also explain how we can use that in the broader research on health inequality. So to give you an image on what socialization is, I usually use an example from Norbert Elias, which is using the example of Robinson and Friday on their desert island. They are alone on their desert island. They have no external supports regarding their place in society. They have no loved ones, no family, nothing. And so they could appear as men without society, generic human beings that are destined to act in the same way within the material constraints of the island. But even without being materialized on the island, the social aspect continues to have an impact on them. They carry with them the society that built them in that way and not in any other way. And it is really written in their body that there are some necessities and resources, some tastes and distastes, some needs and capacities, and even a certain relation to the body with somatic sensations and health-related issues. And so those individuals, and that follows on what Owen said this morning, those two individuals will act differently. They will not be passive, they will be active individuals, and they will act upon their tastes and distastes and needs on the island in a different way, but also in a socially determined way, without being passive regarding the situation, but by being socially determined and being active in a certain way and not in another way. Socialization processes are the processes that produce those two different individuals and those two different bodies before they arrived on the desert island. So socialization is a way that society changes and shapes individuals, the set of processes where an individual learns and acquires certain ways of thinking, of being, of acting that are socially situated, as Nathalie said this morning. By giving this definition and not another one, I am choosing between different possibilities in terms of sociology, and I'm isolating the key elements that, to me, dominate in French sociology, even though I am biased because I did also work towards the exception of that definition in French sociology. It is a definition that goes back to Durkheim in his text on education from the beginning of the 20th century, to Bourdieu. Socialization for him is the sociogenesis of dispositions. So there is no methodological individualism in my presentation, but from Durkheim to Bourdieu to then Bernard Lahire, who stabilized the dispositionalist approach of socialization from the 1990s. This specific definition of socialization highlights the multiple processes of incorporation of dispositions constitutive of the individual by their class and gender position, their experience, the education, whether it be implicit or explicit, that they're subjected to. Individuals incorporate the social world in which they evolve in an unconscious manner, and that becomes and they become a certain type of person or another type of person. In families where parents graduated and went through a higher education, children embody that and become more familiar with school. They have a certain type of relation to language, to food, to boredom, to activity, etc., etc. And so individuals become one type of person or another, but they also become a body or another. For example, gender socialization, those implicit and explicit educations create tastes, behaviors from very early on that really differ between children who grow up as girls and those who grow up as boys.
Il n'y a pas d'opposition.
And so there is no strict opposition between material conditions to existence that we started talking about this morning and socialization. And socialization is not a spiritualist or culturalist approach that would not include the material conditions to existence. On the contrary, the space in which we evolve, housing, constraints, a term that's been used by our two speakers this morning. They said it was something that we could work in social sciences when it comes to health inequalities. So the space that we evolve in, housing, constraints, at work or at home, hours, all of those are a socialization element, and individuals are not floating in in an ethereal space. And finally, when we talk about incorporation, it's also looking at the process itself that I'm speaking about. In most research, socialization is considered as something that's being done. It's a finished product, and we see it in its crystallized form in an individual, in the outcome in an individual. This socialization is seen in the bad school results of disadvantaged children, or the worst results in mathematics with girls, for example. It's all about taste, distaste, recurrent practices, and the link with a social position or relation to hierarchy. But it's also about giving a specific goal, ambitious goal, studying socializations that are actually happening currently and analyze the incorporation of dispositions themselves and administering proof of that. So to paraphrase Bourdieu, it's about going from the opus operatum, so from the finished individual, to the modus operandi, which is the self-construction model and the generation of practices, what generates practices. It's not always easy when we come from an inobservable thing that we can't put under a microscope like we would with a cell or a biomarker or a social practice even. And it's always presupposed. But in the socialization, we like ambitious tasks, and so our goal is to approach socializations that are currently happening and to administer empirically the proof of their existence as such, as products of socialization, and not directly as class behaviors linked, for example, with material resources or material conditions to existence, as I was mentioning earlier.
Cette tradition française, dispositionnaliste,
this French tradition of socialization sociology benefited in France from a certain type of acknowledgement, scientific, professional. One of the
porte ce nom, donc là non plus.
French sociology associations bears that name. Again, it's also something that I'm a member of that association, so I took part in that. It is part of high school programs in the socio-economic science curriculum, and I would say that socialization is a recurring theme in classes in all sociology departments. The fields that it studied it are numerous, but there's still a place where we didn't do a lot of work in terms of socialization, and that is the field that we're working on today, and that's the field of health. So I will talk about why sociologists in socialization didn't study health, and I will give you some exceptions that are quite famous as well. For example, in spite of the omnipresence of the body in Bourdieu's work, health is not a huge part of that and not really linked with the question of habitus, even in a work like The Distinction, that is specifically looking at diets or sports.
Partie manquante de la distinction sur la médecine et la santé.
There is a lack of research between medicine and health. An article from 1971 from Luc Boltanski that is called The Social Uses of the Body. This text is over 50 years old, but it benefits from, but it is quite topical today. And again, this is also something that I've been working on at Gendhi. We considered that he was sufficiently relevant today to get it translated. And so it will be published very soon with several commentaries, including the Gendhi commentary in a number of journals where Janet Chim was an editor, and we thank her very much for that. It's a text that is a toolkit for the study of health inequalities. Boltanski describes somatic cultures of different social classes, interestingly social, and he explains the consistency between some corporal practices like eating, drinking, working, but also taking care of your body, going to the doctor, etc. Those class relations to body and health govern some somatic sensations and their expressions. For example, the feeling after getting a carb-rich meal goes from comfort for lower class individuals to the sensation of feeling heavy for higher class individuals. Some individuals from the middle and higher class, and some genders, women more than men, are described as having been taught to listen to their body and having been taught on how to communicate them clearly to their doctor. The interactions between patients and doctors are analyzed by Boltanski as class interactions that link individuals with habitus and different social classes.
Autre zone d'ombre, dans ces multiples travaux en sociologie de la socialisation.
In the multiple work done on sociology of socialization, another researcher focused on that topic, there are two studies that are interesting to mention here and that constitute exceptions. Those two texts that are on the slide are both on socialization and health in childhood at 5 and 11 years old. And they say that young class bodies are generated in childhood based on diet, clothing, care, and that is defined by the way that parents deal themselves with health and the care for their own body. I will also mention two surveys that I carried out on those questions. They are 20 years apart, and they are. And I'm going to go into detail on the socialization processes that are involved in mental anorexia and stroke. So socialization and sociology of anorexia. This is my PhD research based on a survey that was done during the last century with interviews done with anorexic patients and observation of the services where those patients are hospitalized. With a university hospital, a psychiatric clinic, etc. Interviews with their doctors, their teachers, and interviews with teenagers that are the same age as the patients, all girls. The goal was to look at the health inequalities and to understand the social recruitment of this pathology in terms of gender and class. First, the strong prevalence amongst female patients. And it's one of the pathologies where there is the strongest prevalence of women. 9 out of 10 patients were women at the time of my research. And second, the recruitment in the middle and higher class, so clearly biased towards the higher social classes. It's quite atypical in health inequalities. In this research, I'm looking at the anorexic care career, looking at the different steps. What do the surveyed do before putting this career in the social space? Who they are socially, what they learn to be, so girls from middle and high class, and that can allow to explain what they do during their anorexic career. In this work, in the anorexic career, I'm showing the socialization fact of gender and class on the practices of the surveyed, so their practices in terms of diet, sport, school, their tastes, their taste for some certain food, their taste to some somatic sensation as well. There is a taste for this feeling of an empty stomach, for example, for some of them, and their vision, their perception of the world.
Un rapport spécifique au destin corporel et social et un élitisme corporel et social qu'on peut rapporter à leurs conditions de socialisation et à leur socialisation de classe et de genre. Deuxièmement, à l'hôpital, c'est-à-dire dans la phase hospitalière de la carrière, je fais apparaître la socialisation hospitalière en train de se faire, qui constitue une entreprise de resocialisation par l'hôpital dans les différents domaines pratiques de la carrière anorexique, mais aussi une socialisation institutionnelle à de nouvelles conceptions de soi et discours sur soi. L'hôpital travaille ces conceptions et travaille...
And a discourse on oneself. They work with patients and they see if this type of discourse is reflected on or not. So I look at the inner socialization, this socialization of patients, their resistance that they manifest towards the medical profession, and this is very much feared by health professionals. I highlight how this resistance brings up a relationship to the world and also the experience of hospitalization experience for those who became, after different hospitalizations, different interactions with health professionals, which have become patients that are professional, quote-unquote. In this study, these socialization processes, which I am analyzing in the making, this allows to account for the possibility of this anorexic career, the resistance towards the members of the institution, which aim to stop it. If I have perhaps 20 to 25 minutes, I'm looking at Anne here. Yes? Okay, great. Otherwise, I would go faster on this survey. I'll take the time. This second study, which is more recent, is on the recovery of post-stroke issues. This was conducted in a neurology department specialized in strokes in university hospitals, and also the rehabilitation departments of the same hospital as in the private center of rehabilitation. By looking at these services, you look at the gradient of health per class and gender inequality in this recovery of strokes. You see that some of those patients are more impacted by strokes. Women live longer, so they are affected more than men. They die more from it as well, and the recovery is not as good compared to men. In addition to that, these recovery inequalities are related to access to medical care, but also to differentiation as to the care of those patients. If you compare the care according to class or gender, it remains predictive whether it depends on how you look at the recovery of these missed competencies. So I've derived from that a number of observations. Who has a stroke? I look at the manifestation of corporal and health socialization in the risk factors of the stroke, which are social differences, class differences, diabetes, smoking, and so on. And we see the frequency of those risk factors for popular classes. I also see the proof of gendered socialization patterns for women, and this explains a diagnostic which is not as good when it comes to strokes. And this brings to mind another presentation, the one by Nathalie Bajos, and I explained that the time of arrival to hospital differs according to the gender, and women sometimes arrive 3 times later to the emergency services, even though they have a better knowledge of strokes and their symptoms, meaning a better information. In terms of rehabilitation, I've also observed, so post-stroke rehabilitation, I've observed the manifestation of gendered socialization, especially in re-education for women, and also the relationship to the educational aspect of hospitals and the differential hospitalization processes. So this has allowed me to highlight the existence of an educational form of this hospitalization and socialization, in particular for those patients who have suffered strokes, but which have a better path, let's say. I've discussed about this with Seth Holmes during the Global Social Health Project, and this might lead to a number of publications to come. The notion of socialization, this allows for the notion of socialization shows inequality in class and gender, the possibility of having a stroke, the efficiency of hospital rehabilitation. So this notion of socialization can explain health inequalities and recovery differences, and this is highlighted via epidemiological association. To conclude the first part of my presentation, I would say that within Gendhi we are convinced of the interest of this notion of socialization. This is why we've given priority to this in our big picture. We want to highlight what misses in terms of the links between socialization and health. We want to systemize them for our model of analysis. I will present the different researches that are ongoing within the project.
La notion de socialisation est donc potentiellement au cœur de tous les...
This is potentially at the heart of all the highlights of our study. Oui.
Bien sûr. Désolée. Je ralentis un tout petit peu.
The speaker says that she will slow down in her presentation. So we are studying socialization for themselves, and this is something that's related to a disposition. We know that we are being interpreting, but while we are doing our presentation, it's difficult to account for this. So in the Gendhi format, we're looking at socializations. This is the second level, which is in the blue circle on the right, but we also study the explanatory role of these socializations in the perception of symptoms, access to health, and how health is managed. Horizontally, we look at the explanatory role in the succession of the different states of health and through life. I will present slides that have been worked on with different researchers. So these slides will reflect the work of my colleagues. I would like to thank them for their participation. So these are ongoing researches with different conclusions. So the results I will present will differ from the expectation. So this is related to the Gendhi project. So now, the research led by Amélie Beaumont and Sarah Niquez, focusing on 6 families with hundreds of hours of observation in total, with interviews with families, parents and their children. We look at different classes within these families. The survey focuses on 2 children in primary school between 6 and 11. The elder is a boy and the younger one is a girl, to look at the socialization based on gender within the same family by neutralizing the role in the Delphi. So each researcher has been following 2 families on a day-to-day basis, at home, during their travels, extracurricular activities and medical activities at the doctor, at the pharmacy, and so on. So this is an observation all around via looking at socialization of these families, diets, hygiene, medical monitoring, and learning of relationship to the body, to health, according to class positions and gender positions, and also migration. So these researchers have also looked at ordinary health practices and their socializing impact, or how it is managed by parents or not. If we look at understanding health inequalities within the Gendhi project, the study shows the different relationships to the medical world, how it is embodied from childhood through diets and physical activities, embodiment via trust we might have towards the doctor, also a preventive rapport to health. It also shows how there are socializations that are not related to health, and in particular, how relationship to health are part of social family living standards, and relationship to time, to language, and other aspects. The second study on the health of families, Shirin Abdul Karim, via mixed methods with a quality part, interviews carried out with 35 families with young children and infants, and observations of medical consultations in 3 different pediatric care facilities. The thesis of Shirin looks at the primary socialization of children below the age of 3, looking at health in particular with frequent medical appointments. There's also a question as to the secondary socialization of parents, how parenthood reconfigures the relationship to health and the medical expertise of individuals according to gender, class, experience with children, and migratory experience as well. So this is a moment of socialization to health, which is intense, differentiated in terms of gender for mothers and fathers, obviously from a social point of view. So Shirin shows how to understand social variations on a daily basis, preventive attitude, the use of medication, the perception of vaccines, and also the institutionalization of these families in medical facilities based on their experience with the medical world. This will contribute to understand why women are more interested in health, which contributes to explain how they have it's easier to give a diagnostic when they have health problems. Now, a study by Jeanne Joudinou, focusing on teenagers. This research is based on ethnographic fields carried out in 3 secondary schools for a period of 1 year. In this field, she made observations in the different nursing facilities of schools, canteens, or during recess as well. There was a number of observations made on the socialization of bodies. Interviews were conducted with adults, nurses, professors, within establishments. Interviews were conducted with teenagers as well, from 12 years old, to look at their family socialization, their living conditions. Interviews were conducted with parents, parents of some of the respondents. These interviews will be carried out 2 years later after the beginning of the study. This monitoring in time will highlight the effects of socialization processes as they happen. This will allow to understand how the perception of somatic sensations, pain, heat, fatigue, and how this is built with socialization processes. The idea is to question how teenagers define what is pleasant, unpleasant, what is comfortable, uncomfortable from a physical point of view. In addition to that, in addition to the possibility of understanding the effects of family socialization, this research will highlight the role of schools in socialization via health. This leads to a better understanding on the feelings or the experience of symptoms. Think of the Gendhi diagram. So how this plays out in the perception of symptoms, the interactions with the medical world, and how it is different according to class, gender, race, and age. Also, we can look at the biological aspects from somatic perceptions, what sensations are produced via which social conditions of life. This will help understand better the Gendhi diagram. When we decide we need medical help.
No, it's okay. Thank you. I can, like a very a southern lady from the. I can do both. Thanks. Avec la thèse de Juliette Bontemps.
So with Juliette Bontemps and her research, we're looking at the life cycle from adulthood and the middle age and how cancer is managed. There's a poster in the biology department of the Collège de France on this subject. So there are different sequences of observation in 3 different hospitals, focusing on oncology, consultations, outpatient care, and multidisciplinary councils. There were interviews with patients, their next of kin, with their oncologists to target the 3 aspects of this interactional triangle, which we often bring to 2 aspects, patients and doctors. But via this research, we can also highlight the triangular aspect of these interactions. So Juliette is really looking in real time the impact of previous socialization aspects. So it's a symmetry to the first research I presented earlier. So corporal socialization based on class and gender. Juliette also studies the social construction of bodies, social variations based on class and gender, of relationships to health, and more specifically to relationship to cancer, as well as a social variation of the relationship to doctors and health professionals. And this is a guiding thread in my presentation from the beginning. It's also the impact of socialization, which is not related to health itself. Juliette will also look at how this colorectal cancer is managed at the time passed with doctors, the relationship to care, to domestic work, the relationship to paperwork and the administrative tasks, which differ if we look at different classes or genders. Also, the impact of previous socializations when it comes to colorectal cancer, how patients are managed, what their day-to-day life is, also looking at gender equalities in this day-to-day life. It also shows inequalities in the life of a patient, how a patient looks at its medical path, looking also at the relatives of these patients and the previous socialization before they had cancer. She will also show that to look at these inequalities in health, interactions between patients, health professionals, and relatives is very important.
Enfin, l'enquête postdoctorale de Martin Sarzier nous amène
finally, the postdoc research of Martin Sarzier takes us from childhood, adulthood to older age. This survey is carried out in an outpatient hospital for people with early cognitive troubles. Martin carries out observes workshops with different types of medical professionals and physiotherapists, speech therapists, etc., and carried out interviews with some of those patients who started receiving treatment about 3 months ago. This research is looking at socialization for individuals of an older age. Usually older age is seen as the age of loss rather than the age of new learnings and new incorporations. So this survey is investigating the socialization to the aging well process in those services, looking at the professionals in those outpatient care hospital and what they do to limit this cognitive loss and to stimulate patients on a day-to-day basis. And this rehabilitation appears to be stuck in this school format in hospital. And so this research will allow to show that this socialization work towards aging well has differentiated impact depending on previous socialization of patients. Not everyone can be re-socialized in the same way.
Au terme de cette présentation,
I'm concluding this presentation. I hope I convinced you that the socialization approaches contribute to explain first bodies and different bodies and different health states, but also the relation that individuals have with their body and with their health. And it then comes to highlight the risk factors of pathologies and health status, as well as the social variations when it comes to the experience of the symptoms and their care for it, and the access to the middle of the graph. Second, the interactions between patients and doctors. A socialization approach contributes to explain interactions between doctors and patients as interactions between socially disposed individuals to act as they act and socially prepared to act as they're going to act, and the impact on the care that is provided with patients who are not generic individuals but who have been shaped by their past. And finally, as with regard to socialization, health, just as other social processes, appears to be the result of a the result of the meeting between individual dispositions, interactions, and institutions.
Et des institutions.
Institutions, meaning external forces. To really conclude this time, I can speak on what is the key reason this model can work in the framework of public health. I think that in health social sciences, we can sometimes be reticent to situate the explication of health inequalities at the individual level, and Owen talked about this morning, because we're always afraid that this individualization be a responsibilization, a blame, or a naturalization, or a depolitization of the topic. But socialization approaches are a way to examine individual health at the heart or even at the intersection of power relation, but also at the intersection between those different processes, institutional, dispositional, etc., without being in a normative logic or without trying to denounce morally or politically some patients and others, the doctors. This model allows to introduce individuals' cultures without culturalism, without spiritualism, and without hiding material living conditions, pertaining to existence. So this allows to avoid avoid the risks of the surveys that I was mentioning at the beginning, and to work on individuals, work on their tastes, their bodies, without being afraid that we could blame them for their pathology. This model is also a model that can converse well with other models, particularly the one that you will now hear about, Michel's model. It also interacts well with biology, based on the examination of the way that the social world is incorporated. This model avoids a separation between social and biology as two separated worlds that should be, for some, separated, and for me that's the wrong thing to do. We shouldn't separate that in the study of health and health inequalities. And it may be an opinion that will be shared by the next speaker, and I will give her the floor now.